She could at least sound a little nicer. That's what's
Firm, direct.
Am I all set to let people in? Oh.
Welcome, everyone. Thanks for joining again today. I know it's December. It's a busy month for everybody, and appreciate you joining. And we'll give it another 30 seconds or so and let a few more people join. Getting close to our usual crowd here. Liz, would you pull up the welcome slides?
Yeah, that's a good idea.
So glad to see people sharing their video today. We know it's lunchtime, and certainly if we were together in a conference room, we would be eating lunch. So don't be shy about turning your camera on. We really want to see you as well as hear you. So this is our final echo session for December. So thanks for joining. Next slide. So our learning objectives today, we're going to be focusing on pain management options for pregnant women with opioid use disorder and evidence-based recommendations related to that. Next slide. Please do remember to mute your line if you're not speaking. I know it's also easy to be multitasking when you're on a Zoom, and so please just try and stay with us for the hour. Again, just remembering respectful dialogue and caution around using stigmatizing terms. We do follow the ECHO model process, and so we'll start after the didactic session with asking for questions, and then moving to the case and again asking for clarifications and offering recommendations. If you do have any technology issues, there's the MaineMOM Echo at maine.gov, be able to help you. Our goal is really to demonopolize information. Everybody teaches and everybody learns, and I know I learned something at each session, and I hope you all do as well. Next slide. So again, just a reminder, if you haven't turned on your camera, please do so. And next slide. So this session is being recorded. The didactic will be recorded for education and quality improvement purposes. And so just by participating, you are consenting to be recorded. If you don't want to be recorded, let us know at least a week prior to the session that you want to attend. Next slide. And our presenter today is Elaine O'Connor. Elaine has her doctorate in nursing practice. She's the lead on much of this work in the state, and I am going to turn it over to her.
Awesome. Thanks so much, Kelly. Welcome, everybody. Delighted to see you all today. We're going to talk about managing pain in pregnant women with opiate use disorder. Just want to remind folks that I am a specialist in addiction medicine, so I do not deliver babies, and I'm always very clear to tell my patients that you do not want me delivering your baby, because the last time I did that was about 20 years ago in training. So I encourage folks to participate. I do a lot of this sort of counseling around pain issues. I certainly do a fair amount going into the pregnancy if there's issues that come up that require, or sorry, going into the delivery if there's issues that come up regarding pain, and a lot of postpartum pain management stuff. But I'm not in that sort of intrapartum period. So if anybody who actually, is involved in that process wants to add anything to the lecture, by all means, please do so. Next slide, please. So we're going to talk just what Liz had laid out, pain management options during the intrapartum period for pregnant women, and then evidence-based recommendations around continuing buprenorphine during the perioperative periods. I have no disclosures, as Kelly already mentioned. Next slide, please. So I wanted to think about, when I set out to do this lecture, I've given this lecture a lot before, but I tried to think about it really in the context of this ECHO series, which is that there's a huge array of specialties that are present, which is one of the many things that makes this awesome. So a truly intra-professional group of folks. So wanted to sort of make it usable for everybody. And when I think about pain and patients with substance use disorder, I think collectively our most important role is reassurance. So really being present for mom and being aware that this is oftentimes something that creates a significant amount of fear, of shame, just all kinds of stigmatizing stuff comes into play. So I think what's really important is to just have the conversation with your patient early and often. So support your patient's expressions of concern about how pain is going to be managed or not managed. Is there fear often? And then sort of endorse self-advocacy. So what I really try to encourage patients is to have the courage to speak up, that we're here to help them, that all women who experience childbirth typically experience pain, and this is a normal phenomenon, and we want to be here to support you and help you and take care of your pain. So really try to normalize it and reassure them that we want to hear from them if they're experiencing pain, and we will absolutely help them with that. I also put in some of the most common questions that come up for women, and so in some proposed responses. This is from the state opioid guidance that has been written, and I provided a link at the end. It's through the Maine State Clinical Opioid Advisory Committee. So one of the most common questions is, will I get high if I take pain medications while I'm on buprenorphine? So that's a real fear for women. They feel like, that could be so triggering. I haven't felt high in years. I haven't, used any illicit substances. So am I going to feel high if somebody prescribes me oxycodone? And that's really, it's an important fear that they're experiencing. So actually we tell them that taking buprenorphine lowers the possibility that you'll feel high. So in fact, I really try to explain to women that buprenorphine bonds to that opioid receptor very, very strongly, and really prohibits that euphoric effect of other opioids. So, you can use pain medications and there's no possibility that they're going to feel high, which is, again, a common fear, because it would potentially be quite triggering. The other question I run into a lot is, will I go into withdrawal if I take pain medications while on buprenorphine? Another really common question. So the answer is no, we can absolutely take care of your pain while you are on buprenorphine. I think they use together, they can certainly be used safely. I think what's common for women is that, prior to entering treatment, they may have sort of gone on and off. So they might have been using opioids on the street, used street Suboxone for a period of time, then gone back to opioids. And it's sort of that going off and on that can precipitate that pretty severe withdrawal. So patients will have experienced, okay, someone gave me a Suboxone film one time when I had taken some heroin and I got really sick. Well, that's because of the sequence of events that they used it. So they had all this heroin on board, they used buprenorphine, it pushes all the heroin off and really binds tightly. So that's what precipitates the withdrawal, versus having that buprenorphine already on board, it's sitting on all the receptors, and you can put on something like oxycodone to bind to the rest of the receptors to treat the pain. But again, that buprenorphine blocks the euphoric effect. So really kind of explaining the process, because Typically women will have experienced withdrawal when they've kind of used the two simultaneously together. So it's all about the sequencing, and just sitting down and explaining that to mom is really helpful. Next slide, please. So another common fear, I'm afraid my providers are going to think that I'm a drug seeker. So that will be the term that they'll often use if I tell them I have pain. And again, that's the reassurance, the importance of self-advocacy. Nope, we absolutely want to hear from you. We want to be aware of what's going on because we want to take care of you. Another common question, will I be at higher risk of relapse or returning to opioids if I use pain medications? Another common source of fear, like, oh my gosh, if I take this again, I haven't used anything like this in a long time. Am I going to then not be able to stop using when I get out of the hospital setting? And actually the literature really clearly supports that the risk of relapse is higher if the pain is not adequately managed. So not surprisingly, if you are experiencing extreme pain, you're going to want to address that. So it's very, very safe to be able to use it. And in fact, your risk of relapse is higher if you don't manage your pain. Another question, what if I'm triggered by taking pain medications at home after surgery? So this could be a situation where patients feel like, oh, I don't know if I want to take that entire bottle of oxycodone home after the surgery. Might be because they fear they themselves might use it inappropriately. Sometimes it's a fear that someone in their home might use it inappropriately. So I really encourage people to quote unquote safety plan their prescriptions. And so think about, and I try to do it, it can be a hard conversation to have because you don't want to suggest that someone's going to misuse it. But I usually just ask, do you have any concerns about having, prescription opioids in your home, and let them kind of take it from there. I mean, oftentimes they'll be like, yeah, I'm really, really worried my boyfriend might use it. And then they, of course, can't use it for their own pain. So having a conversation, is there a safe way to take care of this medication? I had a situation somewhat recently where the woman, stored it next door at her mother-in-law's house. That felt like a safe situation for her. So lock boxes, those kinds of things, and making sure that it's out of reach of children. But just having that conversation to see if there's any concerns. And if there's no concerns, she'll say that I don't have any concerns. Next slide, please. So what's the evidence? That's also a really important part of the ECHO series, is to make sure you all know the latest evidence. It is incredibly exciting for me that there is finally a multi-society expert panel of recommendations. This continues to be a clinical conundrum, is the word I like to use. In some ways, it's more straightforward during pregnancy because there's been so much literature out there. Do you stop the buprenorphine? Do you continue the buprenorphine? Do you reduce the buprenorphine dose to some other, 8 milligrams if they're on 16? There's been all this sort of guidance that's been somewhat inconsistent, difficult to use. The nice thing about pregnancy to some extent is that it's often unplanned, right? Like in terms of the delivery. So if you're going to go in and have a stat C-section, you can't be like, 2 days before your emergency C-section, please reduce your dose of buprenorphine. Like that's not a thing because it's not planned. So in many ways, it's somewhat straightforward, more straightforward in pregnancy because it's not particularly well planned. But there's a great statement, and it's the Cohan paper right at the end, and we will send it out afterward, but it came out about a month ago. It is a group of anesthesia, pain management, substance use disorder, and pharmacy specialists. So what's awesome about that is like, it's not just one group saying this, because for a long time, anesthesia said this, and then substance use disorder people said this, and then pain was somewhere over there. So there was all these conflicting recommendations, different societies did something different, very confusing for patients. I tell them one thing and they go, and then the anesthesiologist tells them something different. So it's really nice that there's this global recommendation. So in terms of how I list the recommendations, most of them fell into the category of a grade B recommendation, which is that the recommendation that this is the treatment offered, that there's pretty good certainty that the benefit's going to be moderate or substantial. If it's anything different than that category B, I've noted that. So as we work through this, so planning in the preoperative prenatal period, buprenorphine should not be discontinued because adequate analgesia can be achieved. So that's a really important thing. So I tell my patients, if anyone tells you you're supposed to stop taking your buprenorphine before coming in, come talk to me or let me know and I'll reach out to them. I think across the state, really the standard has become continuing people on buprenorphine, but that's only been true. We've done it forever at Maine General, but that's only been true for the last probably couple of years at Maine Medical Center. And then some other places, in some cases, they still recommend stopping. So I encourage patients to talk to me if that's the advice they receive. Discontinuing buprenorphine can increase the risk of OUD recurrence or harm. If any of you have ever actually tried to do this, it's very difficult. Patients try to taper off. You try to increase their other dose of opioids to cover this opioid debt. and it's very, very complex. And I think that the biggest issue is that if they're discharged home on pain medications and they don't have any buprenorphine on board, that transitions of care can be really, really challenging. You don't want to be in a situation where somebody has nothing. And so really, it is no longer recommended to discontinue buprenorphine. It also, they recommend that you shouldn't routinely taper the buprenorphine dose. So there was, again, this recommendations from some of the organizations that said, you know, well, you should taper any dose above 8 milligrams down to 8 because it theoretically opened up more receptors for which, you know, pain management could be applied. I never found that worked particularly well. It was confusing for people. And then again, there was this sort of opioid debt that you had to make up for because there was that amount of medication that they were receiving above 8 milligrams. So it got very confusing. So the moral to the story is continue the patients on the buprenorphine at the same dose, and that really is the standard of care. I've already mentioned that, you know, again, there's additional receptors out there for pain medications to attach to achieve adequate pain relief. Next slide, please. More planning. So I already mentioned this, but precipitated withdrawal is a risk only when buprenorphine is newly introduced. So that's what I was talking about earlier, that when you have a patient who has no buprenorphine on board, they have opioids in their system and they take buprenorphine, that's when they get sick. It's not the case for patients taking buprenorphine who then receive the full agonist opioids. So it's very important to talk your patients through that. There's literature out there that you should avoid Nubain and Stadol given the possibility of drug-drug interactions. Some of these I'm told are not even used really anymore, but it's in the literature, so I provide it to you. The buprenorphine does not provide adequate pain relief, nor does the methadone used in the treatment of OUD. So that's another really important piece. Some people will say, well, you have opioids already in your system, you don't need any more than that. That's not true. They definitely need more opioid medication to achieve adequate pain control. If the patient is on methadone for opiate use disorder, you should confirm the dose with the outpatient treatment program prior, ideally as early as possible in the hospital stay, and then continue that dose throughout the hospitalization. One thing to note, if your patient's on naltrexone or Vivitrol, you know, I always give the inpatient team the heads up. So I had a situation, it was probably about 2 weeks ago. Patient had alcohol use disorder. She's on naltrexone, which is an opioid antagonist, for those of you that are not aware. And so really important that you don't give opioids to somebody who's on naltrexone because then you will make them very sick. So I just called up to the OB floor and said, hey, heads up, you know, patients on naltrexone. You know, I was sort of hoping the electronic medical record would scream at them if they tried to use opioids, but you don't want to, you know, don't want to rely on that. And you also know that, you know, for those of you that prescribe, I mean, you get warnings every time you enter anything. So sometimes you get a little like warning fatigue. So I try to give the patient team a heads up. The patients will sometimes be nervous about this, but I reassure them you can still have an epidural. There's all kinds of other pain management techniques that we can use. Next slide, please. So treatment in the postoperative period, again, this is the recommendations from the multidisciplinary panel. A multimodal approach, including other medications and regional anesthesia. So epidurals, they have these things called the TAP block, peripheral nerve blocks. There's a lot of places that are using things intraoperatively like ketamine and lidocaine infusions. We just finished a study that looked at spinals with morphines that were incredibly effective in patients with substance use disorder. So again, there was this ongoing question with spinals with morphine, whether or not you could use opioids in that way because of the whole question with buprenorphine. But that's been incredibly effective. So that's one of the things that they're using probably the most. You can use non-steroidals, acetaminophen, muscle relaxants, topical agents, you know, things like gabapentin potentially. I don't love gabapentin, but that's an option. And then there's also all the non-pharmacological techniques that don't forget those, ice and relaxation, mindfulness, specifically peer support was recommended, which I loved. And that could be a doula, that could be a peer support specialist, or just distraction from the pain. So there's a lot of other things you can do beyond just medications. Again, this group recommended full mu agonists with high affinity for the mu opioid receptor. So typically that's fentanyl and its derivatives or hydromorphone, which is dilaudid. Higher dose is likely required, but it does not appear to be associated with the maternal buprenorphine dose. So we don't necessarily see that women who are on 8 milligrams need a different amount than 16. It's just that they probably need more than somebody who wasn't on any buprenorphine. Don't forget that if it's an outpatient prescription, you probably have to do a prior authorization. So it's just important for folks to remember that. Now, the group did say for evidence level C. So not totally clear this is beneficial. They did say for select patients only, consider increased and or divided doses of buprenorphine. I've never found this works particularly well, but I have done it a few times when patients have said flat out, no, I'm not taking any opioids, end of story, like don't even talk to me about it. And so I have increased the dose of buprenorphine in those situations. It's kind of like a last resort thing for me. Like if they won't do it and I'm really worried about their pain, I really try to work on what's the concern about not doing it and try to address it from that angle. But this is a recommendation in some cases you might consider. Next slide, please. Discharge planning. So you taper off the full mu agonist used for pain and continue or return to the postoperative dose. So that is a recommendation A. In other words, you definitely should do that all the time. Net benefit is substantial. Engage in ongoing collaboration with the patient's outpatient buprenorphine prescriber, also level A. I mean, it makes sense, right? You want to get these patients as stable as possible and you want to coordinate care when they depart. Safety plan the prescription, as I mentioned. Safe storage is big. Narcan at home, don't forget to always be thinking about naloxone co-prescribing all the time. Naloxone kits do expire, and then people don't always check that, right? I mean, and they're often only good for a year, and so sometimes I'll say, do you have naloxone at home? Yeah, I got it 2 years ago at the Opportunity Alliance or whatever, and so that's not, that's probably expired at this point. And then really talking about safe medication disposal. So if you don't end up needing all your oxycodone, what do you do with that, and where do you take it? How do you dispose of it safely? So just walking through all those things with your patient. Next slide, please. And these are the resources. So I will happily send the paper. So the second one down is this amazing multidisciplinary panel patient or statement, which again, I'm super excited about, mostly because this has been so inconsistently managed over the course of the last decade. I realize not everybody will be quite as excited about this, but I was really excited about it. And then there's some other statements. There's an ACOG group statement, the first one, and then there's some actually a really good piece on UpToDate if obstetric anesthesia for patients with OUD. So those of you that have access to UpToDate, that's a good option. And then the resource I mentioned from the Clinical Opioid Advisory Committee. So it's just a position statement on perioperative pain management, not specific to pregnant women, but a lot of the things are the same. So that can be useful. And I find things like that, particularly if you're running into a scenario with a specialist that doesn't want to listen to you, sometimes it's helpful to be like, here's the guidance, or can I email you this paper? And it's been quite helpful, I think. And most of the time, again, it's just lack of it's a changing field. So it's not that anybody wants to be mean or unkind in any way. It's just that it's a really, truly evolving field. I mean, this position statement is huge, that we finally have all the specialty organizations on the same page. But again, probably their members don't even know it fully at this point. So important to advocate for your patient. So I want to be sensitive to time, so I will wrap up there, but happy to field any questions. And again, anybody who does inpatient work that wants to add any flavor to that, by all means do so.
That's great, Elaine. Thank you. And yes, I share your excitement about these statements, long needed. So what questions do people have, or any input that people want to share about their experiences with women in labor and delivery? We have a few minutes before the case presentation, so don't be shy.
This is Lynn from Lincoln Health. My question is, I'm actually very excited about the paper as well, because we have struggled with anesthesia at times, and with a rotating anesthesia service, sometimes you encounter new people a lot. But you're talking about buprenorphine, and if we are transitioning, which I'm not sure we are, to Suboxone rather than Subutex, is there any variation in that? Because I've had that question come up.
So great question. No, there's none. And I think the challenge with that is I think lack of understanding about the monotherapy versus the combination therapy. So I think we really are encouraging women to be on combination therapy during pregnancy. So when I say combination, I mean Suboxone, the buprenorphine naloxone combination product. I really encourage patients, mostly from the prior authorization process. I'm like, I can send you a prescription for combination product, and you're not going to have any problems filling it at the pharmacy. If I send you mono products, it's who knows. If people are using their Suboxone correctly, they're really absorbing very little of the naloxone. So they're really from a medication perspective, there's really no difference in the system. So very much both can be safely used. There's no difference, and you certainly don't need to transition to one or the other at all, if that's helpful.
Absolutely.
I had a question. I'm Darlene. I'm the nurse care manager from groups. And one thing that you said about taking home oxycodones after surgery and, making sure there's no concern about it. Coming from a more medical perspective, a lot of times when you're, go through anesthesia with surgery and you're on oxycodone, you don't remember when you took a dose. And it's always helpful to me to have somebody there to distribute your medications, because even if you're not an OUD, you can forget being on that kind of medication.
So that's a great point. And I think maybe like I could imagine telling that story when talking to the patient, right? Because that super normalizes the whole thing. I mean, I think that the art, is having the conversation in a way that doesn't make the patient feel like you don't trust me, because that's not what you're saying. But you could understand how the patient might be like, well, you don't think I can take a bottle of prescription medication home? I mean, how dare you? You've been taking care of me for 3 years. So that's not what you're trying to say. You're trying to say it exactly the way that you said it. Or just or do you have any concerns? I mean, it's kind of the same thing with lab draws. Do you have any concerns about getting your blood drawn? Is that going to be triggering? For some people it is, some people it's not. So really just asking it in as kind and non-stigmatizing kind of way that you can, and making sure that people understand really what you're getting at. But I love your story because that's a really nice way to just make it normal for everybody. Hey, it's hard when you have a pain issue and you go home, and this is not unique to you. I think that's a great story. I may add that one to my to my conversation.
So Elaine, can you talk about like the conversations that you have with women? Do you find that any of your patients will attend childbirth education classes or any sort of preparation for childbirth to start thinking about it in advance, or is there's too many other things going on and that's low on the priority list?
I mean, others can speak to this as well. I think it's a great idea. I mean, I think what I really try to, there's definitely some patients that I feel like are just wanting to take in as much as possible information, and they want, the more they know, that it almost feels the better, and the more in control they are of the whole situation, that feels pretty out of control. And then there's a lot of women who are like, oh my God, you're overwhelming me. And so trying to hit them again meet them where they're at really, and tackle things later on, or really try to understand, 2-3 visits in, what is she really asking for here? Does she want more education? Does she want peer support? Does she want both? I think is what I try to target. But these are great things. And I think so many of these things are now available online in a way that they weren't before. So opportunities to engage with education, with peer support, with meetings in the comfort of your home is great. So I think it's a great suggestion.
I could just share a few things, Kelly, about what we do at Midcoast, and I just have a couple comments, I guess. Anesthesia is always interesting, and there are a couple of physicians who've been here for a long time, but it seems like every time it comes up with a C-section, they're kind of like, I can't give her anything, can I? And I was like, no, you can give her the usual stuff. That's what she needs. But we try ahead of time. So part of what we do in preparation for delivery is reviewing with the patients who are prescribed buprenorphine, what to expect with Eat Sleep Console. And part of that conversation is also planning. They might have a planned C-section, in which it's a wonderful opportunity to talk about what they are comfortable with, and what that they know what the expectations are that we're planning to give them for options for pain relief. And also finding out things that are triggering, or there are patients that certainly say, I don't want any opioids whatsoever, nothing. And it's kind of like, all right, so then we can talk about where they might encounter them, and then they can understand what might actually be helpful for them. Because like you mentioned, the spinals with the Duramorph, the long acting morphine, is definitely very helpful for everybody that gets that. We do the TAP blocks as well. We've worked on trying to implement a ketamine program. We have not actually implemented that yet. We sort of had anesthesia buy-in, and then that person is not doing it any longer. So we need a new anesthesia rep to help us move that along. But that's been something that's been on the back burner. And so we've implemented ERAS a couple of years ago, enhanced recovery after surgery, and that has reduced not just with our mothers that have opioid use disorder, but for all the moms, they've taken vastly smaller numbers of opiates after delivery. The average before was like 65 milligrams per person for a hospital stay, and now it's like 10. But the moms with opioid, prescribed buprenorphine or with any history certainly do in general take a larger number of opiates. And I think it's important that everybody remembers that they do need more. So those are just my comments on it. Thank you so much. This is so needed to have another conversation.
I don't know if there's anybody on from Western Maine Health. They were looking at offering ketamine postpartum as well. Or Katie, do you want to talk about using ketamine, or Sarah's on? They were using it at MaineMed.
Yeah, so Sarah probably knows more. I had met with somebody from MaineMed and we had talked about it a bit, but Sarah can probably speak to it better than I can.
Yeah, I think we started using it probably maybe a year or two ago, maybe a year and a half ago. And we just try to identify those patients that might benefit from it. And we do have a guideline. And there are few contraindications. One of the things that we watch for is this disassociation that can happen with administering ketamine. So you kind of have to pay close attention to that. I think we have had a couple patients who have experienced that. But yeah, we have, Katie, we do have it also in Epic. So we have a flow sheet to assess your patient. But yeah, we've been doing this for a little while and it works really well. Elaine, I was wondering if you could maybe speak more to the use of Nubain or Stadol with a patient who's on buprenorphine, because in my experience too, where I worked before, we never gave it to a patient, but I've noticed at MaineMed that it is sometimes prescribed, and we always have an interesting conversation about whether it's appropriate to do that or not. So I just wondered what your thoughts were on that.
So great question. I mean, where I don't do any actual deliveries, I don't see it. I mean, I think it's the more you want to be concerned when you're sort of using an agonist antagonist because of buprenorphine's own sort of partial agonist properties. And I think that the theoretical concern is like sort of which one wins out and what happens. I've heard plenty of people say we do this all the time. It works fine. But the literature still says don't. And so I try to sort of stick with the literature until that changes, just because I try to give you what's the evidence-based best practice. But I've heard what you've said, and many people have said it to me before. And where I don't do it, I don't do that specifically. But that's the theoretical piece of it, is that, it's got sort of antagonist-type properties, and is it stronger? Does it bind stronger? Does it not? Maybe it's how much of it you give, how quickly you give it after, could be the dose of mom's buprenorphine. Like, I'm not sure what the theoretical, like when it kicks in as being a problem, but it definitely pops up as sort of a drug potential interaction. So just one that you want to be aware of. And, I think like with everything else, if you've used it and it's gone okay, you just use things cautiously. I mean, the same with like, if you're reintroducing naltrexone, for example, after somebody's been on opiates, you do a bit of a naltrexone challenge and you try to figure out when you can start doing it again. And it's just, you sort of learn as you go to some extent, and consent patients if you feel like that's your best option. That's usually what I do anyway. I mean, the literature says 2 weeks for naltrexone, and I don't ever wait 2 weeks. And I say, let's do a naltrexone challenge and see how you do. And so you just have to consent the patient to it. And shared decision making, I think, is particularly key. And it really empowers mom to feel like I'm part of the process and my opinion matters. And really that's the messaging we're trying to always get out there, because I think historically they felt that their opinion doesn't matter.
I think too, going back to the old days when we used to see more methadone, that we certainly did see interactions when women who were on methadone maintenance got Nubain or Stadol, we would see dramatic changes in the fetal heart rate, and clearly the fetus was stressed by that combination of medications. So it's take that into consideration as well. At this point, I'm sorry to end the discussion because I think we could spend a full hour or two on this topic. We do have a case presentation, but before we turn to our case presenter, I'm going to pause for just a second, and Michaela's going to stop the recording. Just a reminder that we don't record the case presentations, just the didactic component is recorded and saved.